Hello, we are the group 1 and my name is Christopher, and together with me is Cindy and Runa and Ella and Yongxin. Our main topic for presentation is heart failure with preserved ejection fraction. Please allow me to begin the presentation. Okay, our main topic is heart failure with preserved ejection fraction. So let's go to the case scenario. Patient arrived with presentation of chief complaint, why do I keep gaining all this weight? So all the signs and symptoms of Mr. Lawrence Smith is listed here. Move on to the following, which is the list of all diseases the patient is suffering. So one is coronary artery disease for 6 years or 6 years ago. Patient also has COPD for 3 years. Heart failure with preserved ejection fraction 4 years, and his last hospitalization is 6 months ago. So patient also has dyslipidemia for 10 years, hypertension for 20 years, and type 2 diabetes mellitus for 3 years. So this chief presenting disease is heart failure with preserved ejection fraction. So what is heart failure with preserved ejection fraction? It is also called as the diastolic heart failure. Heart failure with preserved ejection fraction occurs when the lower left chamber or the left ventricle is not able to fill properly with blood during the diastolic filling phase. The amount of blood pumped out of the body is less than normal. What does preserved ejection fraction mean? The type of heart failure are based on a measurement called the ejection fraction or EF. The ejection fraction measures how much blood inside the ventricle is pumped out with each contraction. The left ventricle squeezes and pumps some but all of the blood in the ventricle out to your body. So a normal ejection fraction is more than 55%. This means that 55% of the total blood in the left ventricle is pumped out with each heartbeat. Heart failure with preserved ejection fraction happens when the left ventricle is not filling with blood as well as normal. The ventricle can pump well, but it may be stiff, so it cannot relax and fill with blood as well as normal. The ejection fraction is 50% or more. Heart failure with preserved ejection fraction may also be diagnosed if the ejection fraction is 40% to 49%. Although the ejection fraction may be normal, the heart has less blood inside it to pump out. So the heart pumps less blood than the body needs. Example of ejection fraction of a healthy heart and a heart with preserved ejection fraction is with a total blood volume, like for example of 100 ml that pumps 60 ml, has an ejection fraction of 60%. A heart with a stiff left ventricle that has a total blood volume, like for example 90 ml and pumps 50 ml, has an ejection fraction of 55%. So Hfpef happens because the left ventricle muscle becomes too stiff or thickened. To compensate for stiff heart muscle, your heart has to increase the pressure inside the ventricle to properly fill the ventricle. So over time, this increased filling causes blood to build up inside the left atrium and eventually into the lungs, which lead to fluid congestion and the symptoms of heart failure. So according to epidemiologic research, up to 50% of patients with heart failure have a retained ejection fraction. And this percentage has risen over time in retrospective studies. The rates of hospitalization and death in patients with heart failure with a maintained ejection fraction are similar to those in patients with heart failure with a decreased ejection fraction. But in clinical trials, the rates of hospitalization and death are higher. So, what are the causes? So, number one is the aging of the heart. As you age, your heart muscle tends to stiffen. It prevents the heart from filling with blood properly, leading to diastolic heart failure. So, other also causes is the pathology. So, one is, like for example, the patient has a history of coronary artery disease, which slow blood flow to the heart muscle or having ischemia or have ischemia. It prevents the heart from relaxing and filling with blood. Then the other one also is high blood pressure or hypertension and aortic stenosis, which is the left ventricle thickens, limiting its ability to fill. So another causes is the hypertrophic cardiomyopathy and pericardial disease. So we move on to pathophysiology of heart failure with preserved ejection fraction. The seminal studies of heart failure with ejection fraction explain heart failure in the presence of normal systolic left ventricle performance by diastolic left ventricle dysfunction, which consisted of prolonged isobolomic left ventricle relaxation, slow left ventricle filling, and increased diastolic left ventricle stiffness. With the advent of Doppler ECG, the diastolic left ventricle dysfunction could easily be appreciated from the mitral or pulmonary vein flow velocity recordings. Abnormal mitral flow velocity recordings suggestive of diastolic left ventricle dysfunction were, however, not specific for Hfpef, as they also occurred in the elderly and in patients with reduced ejection fraction or the systolic heart failure. The importance of diastolic left ventricle dysfunction for Hfpef was recently reappraised by invasive studies, which showed uniform presence at rest of slow left ventricle relaxation and elevated diastolic left ventricle stiffness, and which demonstrated that elevated diastolic left ventricle stiffness limited the cardiac performance during atrial pacing and exercise. So in the absence of endocardial or pericardial disease, the diastolic left ventricle dysfunction results from increased myocardial stiffness. So two compartments within the myocardium regulate is diastolic stiffness. These compartments are the extracellular matrix and the cardiomyocytes. So extracellular matrix, stiffness of the extracellular matrix is largely determined by collagen, relative abundance of collagen type 1, degree of collagen cross-linking, and in Hfpef patients, all three mechanisms appear. So steps of collagen 1 synthesis and degradation is there. And determinants of myocardial stiffness, as I said, is extracellular matrix and cardiomyocytes. In addition to collagen deposition, intrinsic cardiomyocyte stiffness also contributes to diastolic LV dysfunction in heart failure with preserved ejection fraction. Ventricular and vascular stiffening increase with aging, hypertension, and diabetes, and are abnormally elevated in patients with Hfpef. Chronotropic incompetence and cardiovascular reserve dysfunction. So just as diastolic function is impaired in Hfpef, the diastolic reserve is also reduced. Chronotropic reserve is depressed in heart failure with preserved ejection fraction, even compared with older age-matched controls and independent of weight-slowing medication use. Similar to systolic heart failure, this is likely related to downstream deficits in beta-adrenergic stimulation, because the increase in plasma catecholamines with exercise is similar in diastolic heart failure and healthy controls. Autonomic dysfunctions may contribute to chronotropic incompetence as baroreflex sensitivity is reduced and heart rate recovery impaired in heart failure with preserved ejection fraction. So let's classify the two types of heart failure, but let me show you the normal heart function here. So as you can see, in a healthy heart, the left ventricle relaxes to fill with blood from the atrium. Once filled, the left ventricle pumps the blood to the body. For this heart failure with reduced ejection fraction, or also called a systolic heart failure, there is enlarged ventricles, as you can see here. This results from reduced contraction of the left ventricle such that not enough blood is pumped into the circulation. Okay, so the other one which I'm discussing is the heart failure with preserved ejection fraction. As you can see here, there's a thickened ventricular muscle. So for this size, only few amount of blood can fill in. So the left ventricle becomes stiff and does not relax normally. As a result, it cannot fill properly and pressure begins to increase in the left heart chambers and in the lungs. So the increased pressure in the lungs is the cause of shortness of breath. Okay, so we go to clinical presentation. Signs and symptoms of heart failure with ejection fraction are similar to those observed in reduced ejection fraction. They have the shortness of breath, including exercise-induced dyspnea, paroxysmal nocturnal dyspnea, exercise intolerance, fatigue, elevated JBP, edema. Patient with Hfpef poorly tolerates stress, particularly hemodynamic alterations of ventricular loading or increased diastolic pressure. More dramatic elevation in systolic blood pressure in heart failure with preserved ejection fraction than in typical of reduced ejection fraction. So diagnosis algorithms, in contrast to heart failure with reduced ejection fraction, the diagnosis of heart failure with preserved ejection fraction is cumbersome, especially in patients presenting in an outpatient clinic with exertional dyspnea and multiple comorbidities, but without obvious physical signs of fluid overload. To avoid a low specificity when diagnosing Hfpef, exertional dyspnea and normal left ventricle ejection fraction need to be coupled with objective measures of diastolic left ventricular dysfunction, left ventricular hypertrophy, left atrial enlargement, or plasma levels of natriuretic peptides or NP. So this is the metrics of the other studies. So there's diagnostic investigations. Guidelines from the American College of Cardiology and AHA and the ESC recommended the use of natriuretic peptides for assessment of patients with symptoms of heart failure. A brain natriuretic peptide level less than 100 picograms per ml or N-terminal pro-BNP level less than 300 picograms per ml can reliably rule out acute heart failure. A systematic review found that normal ECG findings reduce the likelihood of heart failure. However, normal chest radiography was less helpful for excluding heart failure and moderately helpful for confirming it. Neither ECG nor chest radiography significantly improved the accuracy of diagnostic models when natriuretic peptide results were available. Nonetheless, ECG is necessary in patients with suspected heart failure to assess for evidence of CAD, left ventricular hypertrophy, and dysrhythmia. So management. Heart failure risk factors are recommended guideline-directed treatment of hypertension and hyperlipidemia. Diastolic dysfunction without symptoms is to treat hypertension with thiazide diuretics, ACE inhibitors, or non-hydropyridine calcium channel blockers. Symptomatic heart failure with preserved ejection fraction and hypertension are to treat volume overload with diuretics. Consider use of beta blockers, ACE inhibitors, and systematic heart failure with preserved ejection fraction without hypertension. Just treat volume overload with diuretics. The ESC recommends diuretics for treating fluid overload in patients with heart failure with preserved ejection fraction. So they recommend combined endurance and resistance training for patients with preserved ejection fraction to improve exercise capacity, physical functioning, and diastolic function. Treatment of comorbid atrial fibrillation and CAD. So for acute heart failure, hospitalized patients with Hfpef should be treated similarly to those with heart failure with reduced ejection fraction with diuretics and supportive measurements. Okay, so next to me is Jongsin to discuss what medications can be prescribed. Okay, thank you.
Hello, my name is Elsie and I'll be presenting what medications can be prescribed to this patient. So we'll be prescribing angiotensin II inhibitor to this patient. The first drug is angiotensin converting enzyme inhibitor, which is also known as the ACE inhibitor. The examples are enalapril and captopril. The ACE inhibitor blocks conversion of angiotensin 1 to angiotensin 2 by angiotensin converting enzyme. It blocks the production of angiotensin 2 and decreases production of aldosterone. The angiotensin II is a very powerful vasoconstrictor and is also responsible for hypertrophy of vascular tissues and aldosterone secretion. Aldosterone is primarily responsible for water retention, which can increase vascular fluid volume and also increasing the workload of the heart. Inhibition of the angiotensin II will reduce the afterload in systolic wall stress, which is the vasodilation of the blood vessels, decreasing workload of the heart and pulmonary edema, improving overall renal perfusion. Another angiotensin II receptor antagonist is the angiotensin receptor blocker, which is the ARB. The examples are losartan and losartan. The ARB blocks the angiotensin II receptor angiotensin 1, preventing the deleterious effects of angiotensin II on ventricular remodeling. It's an alternative in patients who are unable to tolerate ACE inhibitor due to cough or angioedema. So for clinical signs for these patients is the BP 150/92, lower extremity edema, and pulmonary edema. So next we'll be prescribing beta-adrenergic blocker. It's a non-selective beta blocker. The examples are carbidiol and labetalol. The non-selective beta blocker binds to the beta-adrenal receptors and thereby block the binding of norepinephrine and epinephrine to these receptors. This inhibits normal sympathetic effects that act through these receptors. It decreases the heart rate, force of contraction of the heart, and decreases myocardial oxygen consumption. As this patient has COPD, we have to monitor for signs of bronchoconstriction, and it is one of the side effects of beta blocker. The clinical signs for this is the blood pressure of 150/92. Next, we'll be prescribing the diuretics, which are the sulfonamide loop diuretic. The examples are furosemide and bumetanide. The loop diuretic primarily inhibits the reabsorption of sodium and chloride in the ascending loop of Henle and proximal and distal renal tubules. It interferes with the chloride binding co-transport system, thus causing its natriuretic effect. Another diuretic is the potassium-sparing diuretic, which the example is spironolactone. It competes with the aldosterone for receptor sites in the distal renal tubules, increasing sodium chloride and water excretion while conserving potassium and hydrogen ions. It may block the effect of aldosterone on arteriolar smooth muscle as well. So the clinical signs for these patients are the lower extremity edema and pulmonary edema. So next I'll be passing over to Ella.
Hi, I am Ella Catrice Diomampo and I'll be discussing about the most important pharmacological class based on the patient's chief complaint. So as from the scenario, the patient's chief complaint is weight gain. So this weight gain is actually due to the excessive fluid volume. As we can see from the signs and symptoms of the patient, which is pulmonary and lower edema, there's dyspnea, there was crackles in the lungs, jugular vein distension, and gaining of 2 pounds daily. So our goal will be to excrete this
So
fluid
diuretics have
by
two
using
types. The
diuretics.
first one is
So how can this
potassium-sparing
diuretics help?
diuretics, which inhibits the sodium and chlorine transporter in the collecting duct. The second one are loop diuretics, which inhibits the sodium, potassium, and chlorine in the thick ascending loop. And the last are thiazide diuretics, which inhibits sodium, potassium, and chlorine in the distal tubule. Some use potassium-sparing diuretics only if there is an indication of hypokalemia, and some don't use it in conjunction with ACE inhibitors because they believe that it can induce hyperkalemia. But recent studies said that it doesn't really affect much. Most use loop diuretics because it inhibits 25 water reabsorption, but it is not that effective after a certain time. They can use these medications in conjunction with one another. So what they do is that they inhibit the said electrolytes from being reabsorbed from the body, which will lead to increased sodium and water excretion. This will result to decreased blood in volume, preload, decrease in pulmonary edema, and decreased stress in the heart. For the patient, it will result into a decrease in weight, better breathing patterns, decreased pulmonary and lower extremity edema, absence of jugular vein distension, lower blood pressure, and better oxygen saturation.
So what are the adverse effects of this medication? So this medication can lead to nocturia, dehydration, oliguria, and renal insufficiency.
Hi, I'm
So I
Cindy,
will
and
pass it
today I'm going
over
to go through the
to
nursing
Cindy.
consideration. So, firstly, before serving the medication to patient, have to check patient's parameter. So, it's not advisable to serve patient the medication if the systolic blood pressure is less than 110 and heart rate is less than 60 for antihypertensive and heart medications. So, if patient is on MBM, do not serve the oral hypoglycemic agents and insulin for patient. So, if patient is going for CT scan, stop metformin. Secondly, we need to know the frequency of medications being served to patients. So for medications such as glipizide and glycoside need to be taken immediately before food and insulin within 30 minutes. So for aspirin usually will be prescribed with omeprazole will be served within an hour. So for Lasix, usually we give it at 8 a.m. and 2 p.m. This is to avoid nighttime urination for patients and disturb patients' sleeping activity. So thirdly, we need to monitor patients' vital signs and evaluate therapeutic effects of medication. So for patient, we need to monitor his parameters closely, such as his blood pressure, heart rate, respiratory rate, SpO2. So we need to perform routine blood tests for patient. This can indicate if the medication is working well for patient, and to weigh patient daily is to check there is any water retention in patient. Lastly, we need to monitor or minimize adverse effect of the medication. So for antihypertensive patient, usually adverse effect is hypotension. For insulin and OHGA, usually is hypoglycemia. For Lasix, it's hypokalemia because it causes patient to lose excessive water. So find out ways to reduce these adverse effects, such as monitoring of posterior blood pressure, reducing post-BP drops such as tight stockings, abdo binder, drink 2 to 3 cups of water before standing up after sleep, and to serve potassium supplement with Lasix or change it to potassium sparing medication. Now I'll hand over to Luna. Thank you.
I will start the teaching point. Administration of medication at home. Consider medication box with a timing, set as a reminder. Keep medication back in the original packaging. Discard the remnants when a medication expires and or contact the prescribing physician for review and or replacement if necessary. Advise and educate him and the caregiver regarding medication dosage, compliance, and the side effects. Symptoms and parameters to be monitored. Look out for at home. Advice to purge like blood pressure machine, glucometer, and the weighting scale at home for monitor. Symptoms of a worsening heart value like a swollen and ankle and feet, unexplained weight gain, and SOB. Ways to minimize copper with the adverse factors. Strictly compliant to food restrictions and medications. Adequate exercise and diet control. Diet control like a low salt, low sugar, low fat means low cholesterol diet. Judging by the latest to his ejection fraction deteriorate from 56% to 53%. Likely he is not compliant to fluid intake or medications, and the heart also slow falling. Conclusion: By understanding the etiology and pathogenesis of the disease, physicians can give the correct medication to prevent and curb the symptoms and no disease worsening. We understanding the medication side effects then allow us to educate the patient and the caregiver what to look out for at home and ways to curb the side effects in the event it happens. It is very important to educate patients on the management of disease to delay the onset of disease progression and improve the quality of life. Those are references. Thank you for listening.